Uh, Thank you, Kumar sir, Asai sir, Vijay sir, for this invite. I will be talking on chemotherapy in locally advanced lung cancer, neoadjuvant and adjuvant. So, as we know that even in early stage and locally advanced stage lung cancer, the long-term prognosis is not good. Though this data is a bit old, but we know that stage 2, the survival is around 50 to 60%, and stage 3 is 25%. We have both local and distant relapses, and distant relapses are much more common than local relapses, especially when stage increases. Most of them recur within 2 years. So these form the basis of why we need something more than surgery. So from IALT trial to LACE meta-analysis, there are multiple adjuvant studies which have been done. So we'll go through them. In IALT study, which was presented in 2004, there was 4.1% absolute survival benefit at 5 years with adjuvant chemotherapy. The drugs used here were cisplatin doublet, but the partner chemo was variable. When this was updated at 7.5 years, the hazard ratio was 0.91, crossing unity. So it lost significance. Thing to note here was that around 33% patients were stage 1 patients. And in all these older trials, the AJCC was different than what we are using currently. The second trial was JBR10. Here, stage 1 and stage 2 patients were only taken. The absolute difference was around 15% at 5 years, 69% versus 54% with hazard ratio of 0.7, not crossing unity. And here, vinorelbine and cisplatin was used and was compared with observation. The benefit was maintained at the long-term analysis at 9.3 years. The benefit was largely driven by stage 2 disease. As we can see on Kaplan-Meier curves on the right side, stage 1 disease was not showing benefit with addition of adjuvant chemotherapy. Then came Anita trial, where stage 1B, 2 and stage 3A patients were taken post complete resection, and there was around 8.4% absolute benefit at 7 years. Again here, cisplatin vinorelbine was compared with observation, and in the subset analysis, it was shown that benefit was largely driven by node positive disease, and 0 patients didn't have much benefit with adjuvant chemotherapy. This is the most important meta-analysis for adjuvant drugs, LACE meta-analysis. The overall survival plot showed that hazard ratio was 0.89, non-crossing unity, when individual patient data from 5 largest trials were compared. So around 4,500 patients were there with median follow-up of 5.2 years. 5-year absolute benefit was 5.4% from adjuvant chemotherapy. Benefit varied from stage to stage. For 1A, hazard ratio was 1.4, which was worse. So 1A should not be given adjuvant chemotherapy. 1B, again, hazard ratio was 0.93, crossing unity. So one need to be cautious. We need to select patients very well if we are giving adjuvant in 1B. Stage 2 and stage 3 patients should receive adjuvant chemotherapy. Hazard ratio is 0.83 in both stage 2 and stage 3, not crossing unity. Again, the patients with good performance status had better benefit with adjuvant chemotherapy. And again, it was shown that platinum doublet, the counterpart drug, was not significant as per LACE meta-analysis. Then in 2010, we had LACE, the subgroup analysis of only cisplatin vinorelbine group, where 1,888 patients from 4 studies were taken. The 5-year absolute benefit was 8.9% with hazard ratio of 0.80, which was better than what we saw in LACE meta-analysis with all the doublets. So according to stage, from the same cisplatin vinorelbine meta-analysis, stage 1 5-year benefit was 1.8% with hazard ratio of 1.01. Again, reiterating that even cisplatin vinorelbine should be avoided in stage 1 patients. Stage 2 5-year benefit was 11.6% with hazard ratio of 0.74. Stage 3 5-year benefit was 14.7% with hazard ratio of 0.66. So cisplatin vinorelbine was largely standard of care for stage 2 and stage 3 patients based on this analysis. So from all the available data, the 3 trials, LACE overall meta-analysis and LACE cisplatin vinorelbine meta-analysis, it was confirmed that for at least for stage 2 and stage 3 patients, adjuvant chemotherapy should be given. The benefit was there in overall survival at 5 years in all the studies given. So what are the indications for adjuvant treatment? Stage 2, stage 3 definite yes, stage 1A definite no, stage 1B the guidelines varies based on JBR data, and it's said that more than 4 centimeter tumors would benefit. There are some data which say that you can look on the high risk features like lymphovascular invasion, high grade PET SUV more than 10, visceral pleural involvement. But we need to be careful while we are selecting stage 1B patient. Is age a criteria to select adjuvant? So in LACE meta-analysis, more than 65 years patient and less than 65 years patient had similar benefits. So age should not be criteria for choosing adjuvant treatment. But we need to be bit aware that there is limited data for 70 plus patient. Only 10% of the patients were 70 plus, and for patients more than 75, it was less than 2% of patients in the whole meta-analysis. In meta-analysis, it is shown that performance status is an important indicator. So performance status needs to be kept in mind while we are planning adjuvant treatment. Which regimens to be given? So largely cisplatin doublet has to be given. Cisplatin dose more than equal to 300 milligram per meter square showed to have maximum benefit when it was given in adjuvant treatment. Can we give carboplatin in cisplatin ineligible patient? So we don't have any positive study with it, but many guidelines suggest that it is consensus based on expert opinion that you can use only in cisplatin ineligible patient. For cisplatin eligible, everyone should use cisplatin. Try to give doublet and try to give cisplatin at least 300 milligram per meter square dose in total. So this 300 milligram per meter square came from this meta-analysis where the maximum benefit was for patients who received more than equal to 300 milligram per meter square dose. Again, the meta-analysis showed that cisplatin vinorelbine had maximum benefit when it was compared with other doublets based on this meta-analysis. The problem with cisplatin vinorelbine is that JBR10 and ANITA trial both had cisplatin vinorelbine as the intervention arm. So we can see that neutropenia is more than 70% and more than 80% in these trials. Febrile neutropenia of 7% and 9% respectively. And EMS is 15% and more than 15 and more than 25%. So cisplatin vinorelbine is bit toxic that we should consider. So is there any other options? So there is a study E1505 where 1500 patients were taken and different doublets were given: vinorelbine cisplatin, gem cisplatin, docetaxel cisplatin, and it was compared. So the overall survival efficacy wise was similar. The only difference between different regimens were toxicity profile. Vinorelbine neutropenia was 13% and around 9% to 10% of them had febrile neutropenia. Gemcitabine thrombocytopenia was 18%. Pemetrexed was the drug which had less grade 3 toxicity. So in non-squamous patient, pemetrexed is something which we should consider. So the most robust data we have is with vinorelbine cisplatin, but based on toxicity profile, we are safe to use other cisplatin doublets, especially from toxicity point of view. And now we know that efficacy is also similar. Pemetrexed cisplatin, based on GPENG study, the grade 3-4 neutropenia was 0.3% versus 12%. Again, assuring us that pemetrexed is way safer than vinorelbine. So this was all about adjuvant treatment. Do we have that strong data for neoadjuvant chemotherapy? So this is a meta-analysis for all the trials. The earlier trial, neoadjuvant and adjuvant trials were going hand in hand, but because we had survival benefit with adjuvant trials, most of them were stopped early and has not recruited well. So based on this meta-analysis, we can know that the hazard ratio for overall survival is 0.87, not crossing unity. showing that neoadjuvant chemotherapy will have equal efficacy. And based on this Kaplan-Meier curve and hazard ratio of 0.87, there is 13% reduction in relative risk of death, and absolute benefit at 5 years is around 5%. Now, the same analysis showed that the hazard ratio for adjuvant treatment was 0.80 and hazard ratio for neoadjuvant was 0.80. Again, assuring us that neoadjuvant has efficacy similar to adjuvant treatment. So why should we consider neoadjuvant? The major reason is compliance. So the above 5 trials are adjuvant trials where if you see that patients receiving 3 cycles or more is less than 60% or around 60% in most of them, while in neoadjuvant trials, which are the last 4, patients receiving 3 cycles or more is around 80 to 90%. So as we know that we have to give cisplatin 300 milligram per meter square, or at least we should try to give that, which is achieved more in neoadjuvant setting rather than adjuvant setting. So what are the differences between neoadjuvant and adjuvant? Level of evidence is more for adjuvant. We have multiple randomized control trial and a meta-analysis favoring it. Compared to neoadjuvant, we know staging in a better way if patient is operated upfront. Neoadjuvant, we have a theoretical benefit of earlier delivery and benefit in micrometastasis being avoided. Compliance obviously is better with neoadjuvant than adjuvant. We can evaluate response. So we know that drug is acting, we can test the biology of tumor. That is something which will benefit in neoadjuvant and we won't know in adjuvant. So maybe for research purposes, a neoadjuvant is a better strategy than adjuvant. And the adjuvant, the benefit would be we would have a good tissue, and with more and more IO and TKIs coming in adjuvant, neoadjuvant setting, tissue would be an important thing while we plan perioperative treatment. So what are the modern options? So it is out of my topic, but I will just walk through it. That now we have data for osimertinib in adjuvant setting in EGFR positive patient with an impressive hazard ratio for DFS. We are still awaiting overall survival data. For immunotherapy options, we have data both for adjuvant and neoadjuvant setting. Adjuvant atezolizumab in IM power 010 and checkmate 816 nivolumab in neoadjuvant setting. And there are multiple trials ongoing for IO and targeted agents. IO with chemo, IO plus IO, ALK inhibitors in both adjuvant and neoadjuvant setting, EGFR inhibitors in both neoadjuvant and adjuvant setting. So this field is going to be dynamic. So based on this, I would conclude that adjuvant and neoadjuvant chemotherapy should be given at least in stage 2, stage 3 patients, not to be given in stage 1A patient. We should try to evaluate patients when we are giving it in stage 1B, where based on risk factors, you can give or not give and discuss with the patients. The regimens which we should use should be platinum doublet. Cisplatin more than equal to 300 milligram per meter square should be our target. Pemetrexed, cisplatin, vinorelbine are good idea. For adeno, you can give PEMSIS. For non-adeno, you can give cisplatin, vinorelbine. Again, Taxane plus cisplatin or cisplatin etoposide also we have data. So based on toxicity profile, we can choose, though the data is strongest for cisplatin, vinorelbine. And it looks like neoadjuvant and adjuvant have similar efficacy. So we have better compliance with neoadjuvant. So we generally practice and try to give neoadjuvant now, especially when we have locally advanced disease. Thank you.